So, my task today was to talk to you about research biopsies and how you might be able to participate in translational research protocols. It's a passionate area for me, and I think, one of the keys is that, we are gaining on cancer. We are definitely making big strides. So this is the cover of Time, and you can see, and you've heard from our talks, that we've made huge advances in melanoma treatment, both through the use of targeted therapy and also through the use of immunotherapy. But how can we improve responses even further? And so the key really to advancing treatment is to take it one step further than what we're doing as standard practice. And how do we do that? Well, we do that through clinical trials, so enrolling on clinical trials, and also through doing translational research, even in patients who are getting standard therapy, understanding why that therapy is working, isn't working, and what we can do to make it work better. And so what I can tell you from a research standpoint is that, research, has already been done and has already led to advances in how we treat melanoma. So historically, when someone comes in, you heard from Ken Tsai early in the day, when a person has a biopsy that shows melanoma, what treatment should they receive? Well, it used to be that, we really just looked under a microscope and looked at the architecture and, at the tumor cells themselves. And we certainly still use that. And also, what we've been doing is, when appropriate, we'll do CAT scans, MRIs to see if the melanoma is spread. But what I'd like to really kind of take home to you is that now, in 2015, in many cases, in addition to doing these things, we actually do special tests on these tumors to look for genetic mutations and also to look potentially for immune responses. Now, in addition to when melanoma is diagnosed, we are also using these research tools to help guide therapy. And, so when, not only when it's diagnosed, now it's been diagnosed, how can we treat patients effectively and then make sure that that treatment is still working? And so again, kind of historically, before we were doing a lot of translational research, we would start a therapy, we'd wait, we'd do CAT scans in a couple of months and see whether or not the tumors grew or shrank. And what I can tell you now is that, we want to know much earlier than, by a CAT scan 3 months after we initiate therapy. So what we're trying to do as a group is to actually, learn, like Dr. Patel said, to actually look at the tumor before we start the therapy, get a blood draw at the same time so we can eventually develop, a liquid biopsy, if you will, to start the therapy, but then early after we actually initiate the therapy to actually do another biopsy to take a look at that tumor. Is the drug working? And also to get a blood draw. We still use conventional restaging, so we still do those CAT scans and we have that data to compare. But then if and when that tumor regrows, we also take another biopsy and another blood draw, and we learn from that. What do we do with these biopsies and blood draws? Well, we actually do in a research setting, we look for genetic changes, and we also look for that anti-tumor, those killer T cells. We look for that immune response. So, with regard to biopsies, when might your doctor actually ask you if you're willing to have a biopsy? There are a couple different scenarios, certainly clinical indications. So, if there's an abnormal area, either on exam, someone feels, a lump, or on a CAT scan, if something looks a little bit funny on the CAT scan, you might be asked by your doctor or your team, to undergo a biopsy for diagnosis. And then also, I think that the pharmaceutical companies, we're kind of all in this together, and we want to know, if these medicines are working or not working. And so the drug companies are actually building in biopsies into these clinical trials, because waiting 3 months for a CAT scan just simply isn't enough these days. Okay, so I think there's an urgent need for us to better understand how these drugs are working, if they are working, if they're not, what we can do to make them work better. And then a critically important reason that you might be asked if you're willing to have a biopsy is for research. And, again, this is the key to the future and how we can ultimately cure melanoma together, and you can help other people. So how do we do biopsies? So I'm a surgical oncologist, and I do a lot of biopsies in the clinic. I see some of my friends in the room who have participated in these biopsies, and thank you. How do we do them? Well, sometimes, we can actually see little melanoma tumors on the skin or just underneath the skin, and so right then and there in clinic, we can actually numb up the skin around where one of those little tumors is. We can use a little instrument like this punch biopsy instrument to actually get a little piece of that tumor or remove it entirely. And then we can actually look under the microscope, not just look under the microscope, but actually do those important genetic and immune tests to look at the tumors. Sometimes these tumors are a little bit deeper, but we can still get to them in clinic. And this is a case where there was a large lymph node just underneath the skin. And what we did is we actually have an ultrasound probe that we can use in the clinic. And here you can see what that tumor looks like underneath the skin by an ultrasound. And then we actually use this little core biopsy. It's like a little needle biopsy, if you will, slightly thicker though. And you basically, like you saw from Dr. Patel, you can get a little tiny, essentially it's like a straw. You can get a little piece of that tumor, but that little piece of tumor is highly informative. And then finally, sometimes these tumors are quite deep, namely tumors like this seen in the liver. Here's a picture of the liver here. And in those cases, we enlist the help of interventional radiologists to actually help us. And so in this kind of a case, the person would be brought to a CAT scanner. They receive some medicine in an IV to make them a little bit sleepy, and then numbing medicine right above where that needle would go in, and we use that same type of a needle to get that biopsy. Here's a view of what the normal liver looks like. Here's where there's some melanoma in the liver. Now, what do we do? So, I allude to these genetic and immune tests. Well, I can show you just a little bit of what we might do to look at these. So we can actually take one of those little tiny slivers and actually isolate the DNA, those genetic building blocks, and run it on a sequencer, which we have many of here at MD Anderson. And we can actually get what those genetic sequences are, look for those common mutations, which can actually then be used, like Dr. Davis said, to actually know what drug we should be treating you with, and potentially to give you a drug that's highly effective, in treating your particular type of melanoma. In addition to this, we can also do immune tests. And so what we can do a number of different immune tests on these tumors. We can kind of get a sense, are these going to respond to immunotherapy? Right now we're doing this in the research setting. We're hoping to be able to bring this, so that it's used as kind of daily treatment algorithms, so that we can decide, is this a type of therapy that your tumor is actually going to respond to? And so can these studies help patients with melanoma? I can say absolutely, and they already have. Research into the genetic changes and the immune changes have actually already led to advances in treatment. You've seen some of this. I'll just highlight two little vignettes in which they have. And so, rewind back to Dr. Davis's talk, we know that genetic mutations in this BRAF gene can occur in about half of melanomas. And like Dr. Patel said, it's kind of like a short circuit in the cell, where if you get a mutation here, it creates a short circuit and you get all these bad things happening. You get tumors that grow, that spread, that resist killing, that grow new blood vessels, and that can actually evade the immune system. But there's a drug, that's been developed, vemurafenib, dabrafenib, a BRAF inhibitor, that if you take that BRAF inhibitor, you can actually shut this down. Now, we know it doesn't last forever, but, it works pretty well. Now, that's, the initial story, and like Dr. Davis said, it works for a short period of time. And through translational research, as he alluded to, we've been able to understand why it stops working. So this, again, you saw Dr. Davis's slides. Here's before you start on that medicine, the BRAF inhibitor. This is a patient who had a lot of tumors. All these black spots are tumors. And when treated, you actually see those tumors disappear within 2 weeks. But they regrow, okay? So, we, many different people worldwide really joined forces to understand why these tumors regrew when you treated with the BRAF inhibitor, and found multiple reasons why. And, I'll show you that a lot of these, like Dr. Davis said, showed a short circuit slightly lower than where that BRAF was. In addition, we also basically did studies and helped to understand why these tumors shrink. Part of it is because it cuts that short circuit, but part of it is that those BRAF inhibitors actually stimulate the immune system to go fight those tumors. And this is, I think, the same images that Dr. Davis showed, where before people get a BRAF inhibitor, they have no immune cells in here. These are the brown cells of the immune cells, the blue are tumor cells. But within 2 weeks, you get this dramatic influx of immune cells, suggesting that these BRAF inhibitors actually do stimulate an immune response, and it helps, shrink the tumors. But within, 2 weeks or so of therapy, those tumors actually, can actually put up a brick wall, and essentially put these dark blue, little things on their surface, which is something called PD-L1. But we now have a drug for that, right? So we have PD-1, which can go back and attack those cells again. So like Dr. Davis said, we know that these BRAF inhibitors can work, but resistance, to them does develop. They stop working after some time, and it's because of, most of the time it's because you actually get a short circuit slightly lower down, but you treat with two together and you get pretty good responses, okay? But we still have a way to go. Now, what else can we do? And, like I said, we also know that when you have that BRAF mutation, it can actually exclude immune cells. It actually forces immune cells out of the tumor. When you treat with that BRAF inhibitor, you get more immune cells in, and it also, essentially lights up like a beacon, although it shows the T cells that, it's a melanoma cell. Now, if we combine these therapies with, a form of immunotherapy, can we get these tumors completely eradicated? And those are studies that are ongoing. So it would be remiss to not mention the huge effort that's underway here at MD Anderson with regard to the moonshot efforts. And Dr. Gershenwald and Dr. Davis lead the melanoma moonshot program, and we are all kind of a part of it, including you. We also have an Apollo platform, which is basically kind of looking not only in melanoma but across tumor types at doing multiple tests on the tumor and blood to see if we can gain insight into how we treat cancers better. So what I'd say is that you can certainly help cure melanoma through participation, importantly in clinical trials, and also through these translational research programs. And so with that, I'd like to just say again, thank you, thank AIM, thank our speakers, and just say that we're all working together to cure melanoma. So with that, I'll close.